Good morning again. I'd like to welcome everyone here today. My name is Gary Painter, and I'm the director of the Homelessness Policy Research Institute, or HPRI as we call it. It's my pleasure to welcome you to our December virtual research symposium. As most of you know who are on this call today, HPRI is a collaborative of over 40 researchers and policymakers that accelerate equitable and culturally informed solutions to homelessness here in Los Angeles County by advancing knowledge and fostering transformational partnerships between research, policy, and practice. This event is meant to provide an opportunity for a group of researchers to share their findings, for policy and practitioner communities to dive deeper into a particular topic relevant to some of the policymaking choices that we have in our region. Today, we have an exceptional group of researchers and providers here and someone with lived expertise to join us today on Zoom for our final event of the year. We're going to learn more about the interplay between intimate partner violence and homelessness during the COVID-19 pandemic. The program this morning will include a research presentation followed by a panel discussion and Q&A. People's Health Solutions and Hub for Urban Initiatives will first present their research findings, which we really appreciate, speaking on behalf of the Homelessness Policy Research Institute, because there was a need for a lot of rapid response learning to really uncover what was happening during the first few months of COVID-19, in particular for populations who are experiencing intimate partner violence and for survivors who are seeking to be stably housed. Presenters for this first portion include Melissa King, Julian Sakota, who are principals at People's Health Solutions, and Sofia Herrera, Director of Research Planning and Policy for Hub for Urban Initiatives. The panel discussion will follow, which will feature a group of providers from various organizations here in Los Angeles who work on the front lines of intimate partner violence and homelessness. Also include a survivor to share some of her experiences and collectively share thoughts on what we ought to do next. The names of the folks, and I will introduce them later, are Tiffany DuVernay-Smith, who also serves as an advocate for domestic violence. Amy Turk, the Chief Executive Officer of the Downtown Women's Center, Candy Lewis, the Executive Director of Positive Results Center, Christina Cortez, the Manager of Domestic Violence and Systems Alignment at LAHSA, and Elizabeth Eastland, the Executive Director of Rainbow Services. Thank you all for joining us. For many of you are familiar with Zoom webinars by now. Here's just a few logistics. First, please type your questions into the question and answer box throughout the program so that we can field them for the panels and presenters at the end. We also do that at the end of the research presentation. So if you have questions for our research team, please let us know. I encourage all of you to tweet your thoughts from today's event. Our Twitter handle is @HPRI_LA. So at this point, please join me in welcoming Dr. Melissa King, Julian Sakota, and Dr. Sofia Herrera to kick off our research presentation.
Good morning, everyone. My name is Julian Sakota, and thank you, Gary, for the kind introduction. I'm joined by Dr. Melissa King and Dr. Sofia Herrera this morning. We would like to thank the survivors and participants of this study. Also, our community partners made this study possible: Downtown Women's Center, Positive Results Corporation, and Trans Latina Coalition. We also had host organizations who hosted our focus groups and semi-structured interviews in the middle of pandemic. We're really grateful for that. They are Genesee Center, Rainbow Services, and People Concern. And Christina Cortez from LAHSA has been our advisor and a guide throughout this whole study. I'd like to thank her for that as well. And the funding from Hilton Foundation through HPRI made this study possible. So thank you, everyone. I'm going to pass the torch back to Melissa.
Okay, thank you, Jithan. And thank you, everyone, for being here today. So since the start of the pandemic, social isolation, economic challenge, and stay-at-home orders have contributed to conditions where intimate partner violence is more likely to occur. and it's harder to flee to a safe place. So back in April, our team recognized how interconnected these two issues are, and how, because we were already in a crisis moving into COVID, there would be a need for more research on this topic. We really want to uplift the work of Downtown Women's Center, who found last year that an estimated 53% of women experiencing homelessness in LA County are survivors of domestic or interpersonal violence. So what is IPV? Intimate partner violence is any in a range of coercive behaviors used by one partner to establish power and control over another. So it's defined as encompassing physical violence, sexual violence, stalking, or psychological aggression by a current or former intimate partner. So that could be a spouse, a boyfriend or a girlfriend, a dating partner, or a sexual partner. And you'll notice that we use the terms intimate partner violence and domestic violence, or DV, interchangeably throughout our presentation today. And the difference is that domestic violence occurs in the home, and it can include children and the elderly, who we did not include in our study. And intimate partner violence can occur among any partners who meet this definition, whether or not they are housed together. So people of color and LGBTQ+ individuals carry a disproportionate burden of intimate partner violence, homelessness, and COVID-19. And a lot of folks have been asking us why this disproportionate burden. And the answer is that it's complex, and it's a product of how racism and gender discrimination affect safety in our communities, access to services and resources, and biases inherent in our everyday interactions. And you can see to the right of the screen, this is an article by the LA Times that came up in my social media feed over the weekend. People who identify as Black, Latinx, American Indian, and Native Hawaiian or Pacific Islander have had higher rates of COVID-19 as compared to white residents in LA County. And for Latinx, that number is more than double. And this is largely because of living environments and the fact that people of color are more likely to work in jobs considered essential and therefore less likely to have the privilege of working from home. LA County Domestic Violence Council informed us that their hotline calls doubled in the summer of 2020 when we were doing our research. And it was unclear whether this reflects greater incidence, greater intensity of need among long-term survivors, or closures in drop-in centers. And the questions we had were more about what are survivor and service provider experiences and how can we better respond. So we took a qualitative research approach that went beyond what we could ask of incidence data and focused instead on those disproportionately impacted. So our research questions were, how have survivors' experiences of intimate partner violence and homelessness been influenced by the COVID-19 pandemic? What primary challenges have intimate partner violence and homeless service organizations faced in serving IPV survivors during the pandemic? And how could solutions identified by survivors and service providers inform LA City and county government policies relating to safety and systems for preventing and addressing homelessness among survivors? And methodologically speaking, we combined what's called a framework approach that's common in public policy, where we identified policy categories to organize our questions into, and a grounded theory approach that's common in social and behavioral science, where we identified themes organically as they arose from the data. Our methods included focus groups with survivors, semi-structured interviews with survivors, survivor surveys, which captured the demographics of all of the participants in our focus groups and interviews, and key informant interviews with homeless and domestic violence service providers. So our focus groups and our interview guides, as well as the survivor surveys, were developed in collaboration with our community partners. We also relied on collaboration with partners and host organizations for recruitment. So you can see an example of the flyer shared by hosts with clients to the right of your screen. And we anticipated going into this that it would be a dynamic process with COVID-19. So we built in the semi-structured interviews from the beginning as an alternative to focus groups for people who preferred that format to a group. It also allowed us the opportunity to engage privately with participants in Project Safe Haven, which is a critical program to house survivors in vacant hotel and motel rooms in Los Angeles County. And there's no time in this presentation to go in depth on the analysis, but we used a combination of qualitative coding and group discussion of case summaries. And you can read more about that in our full report online. But demographically speaking, the participants in our study identified as female, 74%, transgender, 17%, and trans female. Ages ranged from 24 to 66. Races folks identified as were Latino or Latina or Hispanic, Black or African American, white, Caucasian, and other. And key informants represented all of the service planning areas as designated by Los Angeles County. And with that, I'm going to hand it off to Sophia to walk you through the results.
Great. Thank you, Melissa. It's a pleasure to be here this morning. So I'm going to dive into the results and I'm going to go in fairly quickly in the interest of time. So the first question that we had to answer in our study was, how have survivors' experiences of IPV and homelessness been influenced by the COVID-19 pandemic? And not surprisingly, mental health and trauma were the two themes brought up the most by the survivors in the study. Survivors fleeing during the pandemic described the fear that arose not just from current and chronic traumatic experiences of IPV, but also the fear of facing housing instability and homelessness. Survivors also looking for sanctuary during the pandemic described how during the time of COVID-19, it was difficult to reach out, and more difficult, that is, to reach out to trusted natural supports for monetary aid or a place to stay due to rises in unemployment and the need for social distancing. Community resources deemed increasingly essential to survivors during COVID-19 were, as noted in this slide. And among this, I would like to highlight that legal services were difficult to access, for example, restraining orders and work on child custody cases due to the court system being shut down for working limited hours. From the perspective of survivors, access to shelter is simply tough. And you can see it in the quote that we have here from one of our survivors. Here she says, quote, "I was a single individual with nowhere to turn, no place to go, no family, no friends. I was on the phone maybe 5 hours a day for 2 days looking for some place to go. But because of COVID, there was always the turn away until finally she said, 'I think I can help you.' And they scooped me up and put me in a hotel during COVID. And I finally am in a stable environment now. They helped me. They help that came now with COVID, with the new programs. It was a godsend." End of quote. Survivors had a feeling of being bounced around, as exemplified by the quote. On the other hand, for key informants in our study, it seems that survivors potentially looking for safety through homeless services may have found that the providers there were not equipped necessarily to deal with their safety needs. As it relates to clients and survivors' experiences, we discover from key informants that they have come to the realization that both DV network providers and homelessness systems providers may be indeed serving the same people, the same type of clients. And based on this realization, the LA County Domestic Violence Homeless Services Coalition was established a while back with the goal to create a client-centered system that increases access to safe housing and supportive services for survivors of domestic violence and their families, also with an emphasis on integrated trauma-informed care. And it is within this context that a key informant described homelessness and domestic violence as separate yet connected systems, and more on that later. COVID-19 also impacted the nature in which services are delivered, as it has done with pretty much everybody in the world. All survivors interviewed who experienced housing instability or that were in transitional housing during COVID-19 said that they had accessed services remotely. And key informants describe how domestic violence agencies have revised their protocols and all their safeguards for communicating with survivors, creating safety plans and text messaging systems. The participants actually preferred and recommended a hybrid of remote and face-to-face services, and many described the telephone as their lifeline for accessing help. Yet they also acknowledge that in-person services are essential to establishing trust and therapeutic rapport. There were also some equity concerns. Both survivors and key informants emphasized that remote services are really a privilege, citing a need to equip both survivors and shelters with technology. Next slide, please. So the second question had to do with primary challenges that intimate partner violence and homeless services organizations faced in serving survivors during the pandemic. With the shelter-at-home order at the beginning of the pandemic, DV shelters found themselves shutting down and implementing all types of safety measures, and therefore effectively limiting access to shelter beds. But then, lo and behold, in late April of 2020, Project Safe Haven comes along and fills the gap. Project Safe Haven, as it has been mentioned, is a project of the City of Los Angeles developed to provide emergency services in the form of motel vouchers and supportive services to victims and survivors of domestic violence. And so far, it has helped house and provide services to nearly 2,000 domestic violence survivors and their families. The program is to expire in December 2020. Survivors and key informants have described the challenge of searching for other long-term transitional permanent supportive housing options as a result of the program ending. Another challenge that was mentioned by the key informants was the lack of affordable housing units with rents that survivors could sustain. And they felt that increasing housing choice vouchers or Section 8 vouchers was an important resource for survivors. Key informants also talked about flexible funding as an intervention to meet clients where they are at. And one such intervention is problem-solving intervention currently available to homeless services providers through the Los Angeles Homeless Services Authority, or LAHSA. Flexible funding of this nature has proven to be essential to the effectiveness of several programs, including the DV Housing First model, and more on that later. I'll come back to that. Informants also stated that there is a need for relief funding to be targeted to culturally specific and gender diverse organizations who are serving communities disproportionately impacted by COVID-19 and intimate partner violence. And I really would like us to lift the eloquent voices of our study participants by reading the quotes in this slide. We are still experiencing the impact of systemic subconscious bias and racism. The first quote, when they got there to the DV shelter, they looked at the kids and they were in clothing that they weren't accustomed to. And the people wouldn't let them in because they said that the kid, and the oldest child was just 9 years old, was a gang member because they had on red, end quote. We're also still experiencing discrimination when it comes to non-binary and trans individuals, as they are often denied shelter and housing not just during COVID-19, but also before COVID-19 as a direct result of their gender identity. So I would like us to really zero in the second quote, there is not a specific place that we can refer trans women to who have been victims of domestic violence. People have to go through a screening process, and oftentimes trans women don't qualify. So the third research question had to do with how could solutions identified by survivors and service providers inform LA city and county government policies? Key informants and survivors have suggested the need for a common vision and alignment to serve survivors. They have really described two systems with two separate structures, funding sources, working cultures, and technologies that many a time are serving the same individuals. So from their perspective, there's a need for a common service model and standards for collaboration across domestic violence and homeless services agencies. The Domestic Violence Homeless Services Coalition provides a first step and a foundation for such alignment. Also, at the Los Angeles Homeless Services Authority, they have begun to develop a system alignment process map of pathways by which survivors access and navigate homeless and survivor services, including intimate partner violence, domestic violence, sexual assault, and human trafficking. And this has been done with input from the domestic violence regional coordinators that LAHSA has hired, and also the Domestic Violence and Homeless Services Coalition. One promising interconnection between intimate partner violence and homeless services world has been described in our study by both key informants and one survivor. And this was the Interim Emergency Transfer Plan, or ETP, which LAHSA began implementing during COVID-19. And basically, it stipulates that participants and tenants experiencing intimate partner violence in subsidized housing can request an emergency transfer to safe housing in a comparable unit, even if it's classified or funded as a different type of shelter. Key informants and survivors highlighted the need to achieve a no wrong door approach to service access that does not place the burden on the survivor to choose the most appropriate point of entry into the system. And key informants talked about the domestic violence housing first approach as a successful and promising model that has also been evaluated in Southern California. The domestic violence housing first approach focuses on getting survivors of domestic violence into stable housing as quickly as possible, and then providing the necessary support as they rebuild their lives. The model has been successful in eliminating housing as a reason for survivors to stay in abusive relationships. And the evaluation in California identified 4 processes that may be key to successful implementation and scaling up in LA city and county settings. And those are flexible funding to obtain housing and eligible expenses to support clients, survivor-driven trauma-informed advocacy to maintain housing, agency relationship building with community partners to build housing stock and build goodwill, and organizational culture shifts. Project Safe Haven aligns well with the domestic violence housing first model, since it also involves a rapid rehousing approach that involves a more time-limited stay in scatters, and then subsequent placement in scatter site units. And finally, community education and awareness was the 4th most commonly mentioned topic in survivor focus groups and interviews. And many describe situations where violence or homelessness might have been prevented if, for example, teams responding to 911 calls, including social workers or their faith communities, had advised them to leave an unhealthy situation. I would just like us to read the quote that we have here to uplift the voice of our survivors. Quote, "Most of the time, there were several police officers that will come, 4, 5, 6. I mean, If they could have put some of those funds and connected me to social service, some kind of service organization, and then that person could have joined the team. We don't need 6 police officers. We need however many, but at least one person for me. All of them were for him. Nothing was for me. End of quote. We also found that there is a need for public education programs designed to generate knowledge and awareness of the contributions and rights of trans and non-binary individuals, to change beliefs about their right to seek shelter that matches their gender identity, and increase understanding of the impact of violence and discrimination of trans people. But we should not be, we will be remiss, I should say, not to acknowledge that there is a tension that service providers experience in terms of promoting services through community education, since they have at this time limited resources for the need. And that was a tension that the key informants also talked a lot about in our study. So this is just a very quick summary. You can read our report for more specific findings and to hear the voices of our survivors. And I will pass this on now to Juhan, our next team member.
Thank you, Sophia. We would like to highlight a couple of policy recommendations we proposed in the report. You can access all 10 of them in our brief or full report online, but we're only talking about, we would like to just highlight 4 of them for the interest of time. We proposed recommendations at 4 different levels: policy, system, organizational, and individual level. So for policy level, our study found that Project Safe Haven has been a crucial crisis housing resource for survivors during the pandemic, as Sophia mentioned. It also addresses the gap in resource for single adult survivors and the families with older children who face more challenges like accessing shelter resources, especially during the pandemic. Extending the funding or finding new sources of funding for this program will allow further research on effectiveness of DV Housing First model and long-term outcomes of Project Safe Haven as well. At the system level, we need policies and regulations to ensure inclusive decision-making and equitable access to city and county funded IPV and homelessness services. The communities disproportionately affected by COVID-19, IPV, and homelessness must be represented in planning and decision-making among agencies who serve them. One way to ensure this is to include reporting requirements addressing indicators of equity and access and outcomes by gender, race, ethnicity, and housing status. At organizational level, we need to talk about mental health of the service providers. Self-care isn't selfish, as it says on the screen. It's important to remember that trauma-informed care is not simply a skill to be taught, but rather a product of organizational context that foster healing for staff and clients. This might include an organizational inventory to understand the current culture and designing programs to help influence norms to be more healing-centered and trauma-informed. Our key informant mentioned a couple of examples of activities that you can do right now with your staff. That includes outdoor meetings, lunches, flexible on-off schedules, mask making and other creative workshops, trauma-informed yoga, and other activities that support connection and healing, and that can be done with social distancing. Lastly, we need a community approach towards IPV and homelessness, including training and public educational programs. Sophia went into this a little more detail, so I would like to only highlight one additional piece, which is the fact that the public education is also a really invaluable tool to help dispel myths about transgender and gender non-conforming survivors and generate awareness of their rights. Also, for public educational programs, we should continue to disseminate information about IPV and homeless services in places that survivors might still frequent during pandemic. So that was some of the highlights from our policy recommendations. And again, the full report, policy brief, and some additional exemplary quotes are all available on our website. On behalf of our research team, I would like to thank everyone for joining us for the presentation, and please stay safe and be kind, and let's stay connected. Thank you.
Thank you so much for sharing, Melissa, Julian, and Sophia, of this work. I think, as everyone can fully appreciate, while the work can be presented in a way that provides critical information, that the work also describes the stories and the traumas of survivors, and to that end, I think it's important for us to kind of sit with that, for a moment, and as we transition to our panelist, one of whom is a survivor of domestic violence, it's important to kind of understand what we can learn and then what are going to be the next steps. And that's really the goal of the panel conversation. Julian, I wonder if you could take down the slides now as we move to the panel conversation. Tiffany DuVernay Smith is an advocate for domestic violence and the Homeless Services Coalition, in addition to being a survivor. Tiffany, if you feel comfortable, I wonder if you could kick off our panel and just share a little bit about yourself, and also share what you hope research like this can accomplish to improve the lives of survivors.
So my name is Tiffany DuVernay Smith. I was in a DV relationship from 2006 to 2012. And I will say that I first engaged mental health 2008 to 2010. And this is during my relationship. And I clearly, now that I know what I know, I clearly was in a domestic violence relationship. I didn't know at the time, but what I was communicating was that I was. And I would have appreciated someone sliding that power control wheel across the table and asking me, did I identify with everything, and help me with my awareness, right? So I quit mental health. And then I ended up coming to a self-realization. And in 2012, I did engage mental health services and domestic violence services. And I noticed that even on the domestic violence side, mental health was not a priority. So it is obvious to us all that any trauma affects our mental well-being. So why isn't mental health a priority when it comes to victims or survivors of domestic, I'm getting my acronyms mixed up, domestic violence, intimate partner violence? It should be a high priority. So I chased down my healing. I went after depression therapy. I went after PTSD therapy. I did 5 years of support groups, but I know everybody hasn't done that. But I'm highly recommending, like, example, like the DV Housing First model was mentioned. So we know housing first is, don't worry about my mental health, don't worry about my substance abuse, give me a place to live, and then I'll take care of myself, right? But if you think about that with the domestic violence, it would come down to, don't take my kids. Give me a place to live. And I'm speaking from a person that I don't have children, but in the support groups that I was in, everybody else did. And some people were court mandated to be there in order to get their children back. So don't take my children, house me and my children, and then assist me in getting mental health services, parenting classes, trauma recovery classes, PTSD support and therapy and groups. And then you have the cognitive behavioral therapy, dialectical behavioral therapy. So the request would be, house me and then reprogram my brain and help me heal. So that's something I thought about while I was listening to the presentation. And then also with Project Safe Haven, I know that there's Project Home Key going on. So I'm hoping that Project Safe Haven is being treated like Project Room Key, where they're transitioning people to the recovery rehousing model. So are the people in Project Safe Haven being treated like the people in Project Room Key, where they're gonna be moved on to housing and not be into homelessness again? I also thought about the batterer. So if you are going to ask me another question, I'm pretty sure it's all going to be answered right here. But when it comes to the batterer, why not batterer's intervention? So I would imagine that the batterer has a lack of nonviolent problem-solving skills, and that they have a habit of using aggression to resolve difficulty. So why not also engage the batterer? And then another concern that I had, so my long-term suggestions revolve around mental health and DCFS,
Great.
allowing someone to stay with their child and heal. And then I heard about ETP on this webinar. Does the victim know about the emergency transfer? Like, how do you actually, are couples doing an intake together? Like, oh, let's bring you off the street. Let's put you at a Project Room Key site. Is your intake done with your intimate partner? Or is it done separately? Does this person know they even have a way out? And hey, let's put you at a Project Room Key site, clear on the other side of Los Angeles. So those are some of the thoughts that I was having while I was listening.
Thank you so much, Tiffany, for sharing both your personal story and also for, combining that with insights of what we can do next. I want to turn to the conversation to some of the frontline executive directors who are just real champions for women who are experiencing intimate partner violence. And I first want to just thank you on behalf of the research team for participating in this research. And so maybe as kind of a transition conversation, I'll start with Amy, go to Candy, and then to Elizabeth. Amy, maybe you could share a little bit about the Downtown Women's Center briefly, and then really just answer the question, why did you participate in this study? What are you hoping to accomplish by being a partner in this work?
Thanks, Gary, and to everyone, especially Tiffany. It's always a pleasure to get to work with you. Downtown Women's Center serves about 5,000 individuals primarily who identify as female through a full continuum of services. In the last 5 years, we've partnered with Rainbow Services to start the Domestic Violence Homeless Services Coalition. And part of our intent of that coalition is to bring together the real voice of people with lived experience, providers, and amplify and create community-based research where needed. So our participation, both as a coalition and as the Downtown Women's Center in this particular effort, was incredibly important. So much to learn and to quickly respond to as survivors were disproportionately impacted by COVID. And I think the policy recommendations that ring loud and clear through this is on the very, very short term, next 2 weeks, our advocacy around maintaining Project Safe Haven and the families who will literally be cut off of the program on December 31st unless the funding continues. And then certainly the long-term solutions that have been lifted up related to mental health access and community awareness of resources and et cetera.
Great. Thank you, Amy. Candy, if you could share a little bit about your organization and kind of what you hope that this research can do to improve our practice.
Absolutely. Thank you. And thank you to all the panelists. This is an amazing program. So Positive Results Center is a nonprofit. We focus our awareness on trauma from a cultural and age perspective. We're a dual agency where we focus on both dating, domestic, and interpersonal violence, as well as sexual assault. But we also address bullying. And a lot of people don't take into the fact there's a lot of bullying in violent relationships. And so the reason that, and our focus is really on working with youth and young adults. We want to train them to be peer advocates and help them to understand what violence looks like. Because we often forget that in an abusive relationship, everyone who lives in that home is also being abused. The children are being abused. And if we do not address them while they're young, they have a tendency to grow up and think either A, I'm the cause of the violence, or B, I become the violence. And so we want to help them to grow up to be healthy have healthy relationships, and be positive, well-adjusted, not dealing with the violence or thinking that it is their cause. And we wanted to participate, first off, because we love the work the agency is doing. And we know that there's not a lot of information that's coming up. There's a lot of speculation. So to really have the voices of the lived experiences as well as the people that are doing the work is important.
Great. Thank you so much, Candy. And Elizabeth, share a little bit about Rainbow Services and kind of what you hope this research can do to uplift the voice of survivors.
Sure. Hi, everyone. Good morning. My name is Elizabeth Eastland. I'm the Executive Director of Rainbow Services. As Amy mentioned, we have been co-leading the Domestic Violence Homeless Services Coalition for the past few years, trying to raise awareness about this very real intersection of domestic violence and homelessness. We decided to partner in this research because we know that the domestic violence field does not have a lot of data around the success that we have with the survivors that we serve. I was amazed with how quickly we were able to implement Project Safe Haven. Organizational level, we put together a program in the matter of 2 weeks. And so, just being able to see that someone was focused on researching its effectiveness has been extremely helpful. And I think one of the pieces around Project Safe Haven that went well is that first the Mayor's Fund and then the City of Los Angeles put aside money specifically for rental support. So for us to be able to access funds to apply to the domestic violence housing first model has been extremely successful for some of the survivors that we serve. We have been able to serve more survivors through Project Safe Haven than we do in our emergency shelter. And with COVID and having to reduce the number of people we have at shelter, Project Safe Haven was truly a godsend for the survivors who were calling and requesting shelter space. So we do hope that we are able and successful in our advocacy efforts to see the program extended, though, and I think it can be a model. I mean, it has become one of the largest shelter in the world, really, for domestic violence survivors, housing, over 2,000 households over the course of time. So I think we have a lot to learn from the program, and I am hopeful around looking at how we can provide even more equitable access, especially to transgendered survivors and the LGBT community, and ensuring that we are being inclusive of all survivors who come to our doors.
Thanks, Elizabeth. And then Christina, maybe you could share a little bit from your perspective in your work with LAHSA, what you hope this research can do to help affect and positively improve practice.
Oh, first off, hi, everybody. Wonderful to virtually be in this space with you all. I know it's been a while. But when I was contacted by the People's Health Solution, I jumped on it because quite selfishly, it felt like a great opportunity to learn about what's going on and try to bring in some of those best practices that have been out there. And I think a lot of it, and just to echo what Elizabeth said, at least for me, I hope to continue the work that the coalition has done to bring awareness on domestic violence and homelessness and the intersection and how it all works in a way where we can share more resources between the two entities, if you will. And that's something that I think LAHSA, as well as the domestic violence regional coordinators who are doing the work on the ground, can continue to push and learn and support the agencies that are trying to be more inclusive when it comes to serving trans folks, or who are trying to serve chronically homeless survivors, but they might not quite have the skills and the knowledge. So that is one of the things that we're hoping to continue to do as COVID and the pandemic continue to impact our community.
Great, thanks, Christina. There's a question in the Q&A from Sarah Hunter about kind of practices around screening and so forth that may be new because of the last few months in the pandemic. I wonder if we could even broaden that question out a little bit. Any of our especially our executive directors who are on the call today, like what sort of practices have necessarily changed? And I'm curious if there been any insights into those kind of forced upon changes that may actually stick, that you may actually do the things you're doing now during the pandemic long term because you felt like actually it's been a better way to serve survivors.
Yeah, I can speak to that. We didn't change much in terms of the intake process. We just modified the intake from our shelter to do intake into Project Safe Haven. I think what we've learned and what we will keep is that we will continue to have some services and especially support groups virtually, especially for survivors who are working or, and have access to virtual technology. It will save on their transportation time and costs to be able to continue to provide services virtually. But for Project Safe Haven, our intake didn't really change too much. It was really based on whether or not we can bring them into shelter or if we have space available in Project Safe Haven.
Candy or Amy, anything that you can reflect on here in the moment?
I think it's been really exciting to see an overlay of necessary training provided to both Project Safe Haven providers and Project Roomkey, coordinated through LASA and in partnership with people with lived experience to train more people on safety planning, the interim emergency transfer plan, things like that we've kind of scaled up the capacity building of organizations through immediately responding to those needs. Interestingly, we've changed a little bit on the homeless services side, how people access Project Roomkey in particular, and who then is prioritized through coordinated entry through permanent supportive housing, which are all things that we need to keep an eye on, especially since we've prioritized older individuals, rightly so, related to COVID health conditions. But we've now created more of a geriatric program, and we need to up our capacity now as service providers to respond to their long-term needs now that they have been prioritized in Project Roomkey and now next couple years through recovery rehousing.
And from my perspective, it's really important that their conversation continues about training providers on trauma from a cultural perspective, because there's not been a focus on that. It's always been, let's get them in, let's get them out. But the needs of African American and Latinx communities are very different. And so to have the conversation on an ongoing basis, as well as to bring in, what I love about this conversation is we're not just talking to the providers, but we're also talking to those with lived experience. And that is critical, to bring the voices of the community into the conversation.
Great. Thanks, Candy. And Tiffany, I wonder if you have any thoughts as a survivor yourself about kind of maybe how you've engaged with, the system resources, with partners, in ways that you think are actually have improved engagement, and perhaps other areas where you hope that there's greater improvement.
So a big hole for me in the beginning is that I was triggered into a depression. So my life of working with children and advocating all over the place just came to a halt.
Yeah.
And being at home by myself, my husband was at work. So just being in the house all day by myself triggered a depression. And I don't think it's because I was actually depressed. I think my body physiologically said, oh, because you're acting like this, let's get depressed. And then all of May, June, and July, I had fireworks going off by where I live. And I don't know if it was a sale or what was going on, but this included M80s and everything else. It totally triggered my PTSD. And as much skills as I had to call on, I was really feeling for the people who actually don't. And so I do notice more mental health support groups. For example, NAMI. And then I also believe that the Peer Resource Center, I saw them, Peer Resource Center with DMH, I saw them advertise like a support group. And then I also know there's so many apps that have come online to assist people. I know DMH had added an extra line to their hotline for people who are in emotional need. I think you just like push 2 instead of going to the regular person.
Mhm.
And then something that I had put in the chat was, so I recently started working for Project Room Key, like real recent, like a week ago. So I'm learning a lot. So I was listening to one of the floor monitors talk, and she was saying how her clients want to go to the doctor. They're older, right?
Mhm.
So what do we do about that? So because of traveling, there's more exposure. Going to a doctor's office, there's more exposure. And if we're trying to keep people safe and not contract COVID, what do you do?
Mhm.
So I'm recommending like on-site healthcare, or even a room where telecare can be provided. Like come in here and plug into your provider and have a discussion about how you're doing and how you're feeling. But just to be more creative on how to meet people's needs so that they
Mhm.
don't leave in an access van or whatever it is to go take care of their health. For the simple fact that they're proactive on their health is a beautiful thing, because some people are not. So to the proactive person who anxiously wants to take care of whatever their medical issues are, and the same with mental health, is everyone connected to telecare or phone calls or video calls for their mental health? So whatever we can do to
Right.
blow out a room where people can engage with who they need to engage with, I would highly recommend that.
Can I add a little something to that?
Please,
It
Candy.
is critical that we address mental health for our providers,
Mm.
because all of us, we ramped up. Where a lot of people went home and just said, okay, let's just wait. We didn't.
Mm.
Our phones were ringing from 7 a.m. to 2 in the morning. And we don't even have a hotline, but people were calling us.
Mm.
And not only that, but when we went home, a lot of our team members went home to senior people, senior family members and children. And a lot of people go to work to get away from home. So now they're at home, they're working, and they're dealing with other people's crises as well as dealing with their own internal crises in home. And so the resources became very limited.
Mhm.
So it's important that we talk about how do we make sure that those that are providing the services are also receiving the appropriate services that are needed. And then also, how do we address the mental health of youth and young adults? And I can share with you one thing that we did. We partnered with Department of Mental Health, and we trained 19 African American transitional age youth on common mental health issues. And it was appropriate. It actually started prior to COVID-19, but then they became the ambassadors and started training their community. And it was awesome to have a 19 or 25-year-old to be able to talk with another 19 or 25-year-old, or even a 15-year-old, or a parent who was dealing with this. So it's critical that we make sure that we support the youth as well.
Absolutely. Well, thanks, Candy. And I know that we're coming to a conclusion. I want to give everyone a chance to say a couple of final words. I'll share with you 3 possibilities to frame your remarks, and you can choose any of the 3 or something else. There's a lot of questions in the chat or kind of comments around issues of heterogeneity within the population of people experiencing intimate partner violence. There may be something there that you may want to comment on. I heard people talk about safe haven and the risk of it not being reauthorized here in this immediate moment. And maybe you want to share something about how we can act collectively to really advocate so that this program can continue in the short term. Maybe you want to talk about some policy issues in the long term, or maybe you want to talk about some research questions that you want to call on members here at HPRI to address in the future. I'll kind of leave it open to all of those, and I'll just kind of call on folks who are here on the panel. Christina, do you feel comfortable beginning this final round of comments?
Sure. Again, thank you all for joining us today. It's very exciting to see how much traction there is in the community. And I think goodness, so many options. I like an option, but I think closing remarks, definitely reach out to your representatives if you can to advocate for Project Safe Haven. Like it was mentioned in the report, and here it's one of those lifelines that is incredibly helpful for survivors in this moment. And unfortunately, DV agencies have been underfunded for a long time, and Project Safe Haven swooped in and filled in the gap. There might be opportunities to make this a long-term program, but who knows? And then other than that, if anybody's curious more about the alignment process, please connect with the Domestic Violence Homeless Services Coalition. There's lots of work to be done, and we could use as much help as we can.
Thanks, Christina. Elizabeth?
Yeah, I mean, I echo Christina's words around extending Project Safe Haven. You know, for Rainbow, we're fortunate that we have other funding to extend it for at least a month, but it does get extremely expensive. And so we want to make sure that we are using our government funds the way that's going to help the most people. And I'll just say, I'm going to go off topic, Gary, and address mental health amongst our staff and ourselves, right? Because this has been such a challenging time. So at Rainbow, we've really upped our wellness support of our staff, including having a volunteer therapist who connects with employees individually, having monthly wellness groups, a monthly yoga group, and then we participate in a thing called the Center for Counsel for people to be able to bring challenges to a group setting to work through collectively. I think it is so important for organizations to not just talk about supporting the mental health of their employees, but to actually do it, because they are the only reason that we're able to continue this work, and we have to have a healthy workforce in order to properly serve survivors. And thank you, everyone.
Yeah, thank you for uplifting that, Elizabeth. And we all know that costs money in order to do that. It takes time out of other work, but it's absolutely critical work. Candy, would you kind of share some final thoughts?
Thank you. First thing I'd like to say is fund organizations, fund nonprofits, and fund organizations that are doing the work that may not actually be a shelter, because we're the first line. People come to us, people call us, people look to us, and then we tell them to contact your shelters. We refer them to shelters. We do all we can to support, and then we can only go so far and then get them in a shelter. Also remember that not everyone wants to go to a shelter. So if they show up at your door, make sure that you welcome them and don't look at them, because especially people of color, they will show up and the needs are really different. So do your best to understand the cultural needs of the person who shows up, whether they are Black, Indigenous, Pacific Islander, Latina. And also, when you look at them and you look at their children, understand that their children are also victims. So don't accuse them of anything. Welcome them in the door. And then last but not least, treat your staff members with the greatest respect, because I often hear a lot of staff members who feel like, okay, so I don't get paid a lot and I'm really treated with a lot of disrespect. And sometimes that disrespect comes from the people who are coming in because they're dealing with trauma. So treat people with the most respect, train your staff, and also contact us or contact some agency to get some cultural training.
Thank you, Candy. Amy?
I ditto with all my colleagues, and I know everyone wants to hear from Tiffany. I know I do, so I'll give my time to her.
Thanks, Amy. Tiffany, final thoughts.
I appreciate the opportunity. And I appreciate you, Amy. You did this on the last phone call too, so thank you for that. First, I want to support everything Candy said, but especially about not wanting to go to a shelter. That was me. I did not want to go to a shelter. I refused. I stayed in my car. I snuck and stayed in somebody's garage. I went into a shared housing situation, which a bunch of people I didn't know, some of them elderly, some of them out of jail and prison, but it was a smaller situation than a shelter. I stayed in somebody's back house. I slept on somebody's couch in somebody's room that wasn't a room, whatever I could to not go into a shelter. So she was talking about me. I think for providers, I mean, you don't want providers, their employees and coworkers to get any type of burnout. So I recommend an app that all homeless service providers, and including the staff, and the same with the domestic violence providers, including the nonprofits, apps and webinars, pre-recorded, recorded, and then rewatched, however, to be able to have a centralized location, like if you need this, it's here. And then as far as advocates are concerned, tap into us. I'm connected to a specific group of women who were homeless as a direct relationship to our domestic violence relationships. I'm also connected to a group of housing advocates who were homeless and are now housed, excuse me. If you need funding, I recommend you contact us when there's opportunities in meetings for public comment, because there's nothing like having 8, 10, 20 advocates speaking out on public comments saying the exact same thing. It moves the pen of the people and the hearts of the people making decisions. And the same with funding for grants. Why not submit written statement from people with lived experience to go in with the funding that you're trying to get? So those are my closing thoughts. Thank you so much for this opportunity.
Thank you so much, Tiffany, for sharing your heart and your experience. Thank you so much to all the panelists who are on the front lines. Thank you so much for the research team who, stepped into doing trauma-informed research in this way so that we can advocate more effectively for the kinds of programs and practices to really serve our community more effectively. And I just thank everyone for being part of this conversation today and for being with some of the webinars and seminars and things that the Homelessness Policy Research Institute has put on. I know that collectively we can act to end homelessness for all Angelenos, and I look forward to continuing to partner with you in the new year. I wish everyone a safe holiday season. I know it'll be subdued, but I pray that you will have moments of light there as well as we face these difficult times. So thank you once again, and we'll look forward to the next time we get together. Bye-bye now.